This lecture is about clinical decision thresholds. Up to now, we have learnt how to evaluate a test using a diagnostic accuracy study. The meaning and limitations of terms such as sensitivity, specificity, and predictive values, and how Bayes' theorem can help us overcome some of the limitations. Now we're going to look at clinical decision thresholds as a way of defining how information from tests impacts on the clinical management of patients. Clinical decision thresholds are points on the continuum of probability where we change our minds about performing tests and starting treatments. You can think of the threshold as a point of equipoise. For example, if the probability of disease is above a threshold value, you might start a treatment, and below that value, you might not. We'll start with a thought experiment to explain a common threshold. Imagine you're working in a country with a high incidence of TB, such as South Africa, and you're locked in a room with 100 identical patients, and you have to decide whether or not to treat them for TB. There is absolutely no way you can tell them apart, so the only logical decision is either to treat them all for TB or to treat none of them. They are quite unwell, lying in bed with a tachycardia and tachypnea. The chest X-ray is suggestive of TB, but the gene expert on their sputum is negative. They've had some antibiotics, which don't seem to be helping much. Based on all this information, you think that the probability of TB for a given patient is 50%. So you think 50 patients have TB, represented here in red, and 50 don't. But as they're identical, you've got no way of telling the two apart. Importantly, in this thought experiment, there are no further testing options available to you. You have to make your decision based on what you know at this point. And what you choose for one patient, you have to choose for all, as they are identical. What will you do? If you choose to treat, the 50 patients without TB will get the side effects of the drugs with no benefit, but the 50 with TB will get benefit. Decide not to treat, and 50 will have untreated TB, but 50 will be spared the side effects. In these circumstances, most doctors would decide to treat all patients for TB, reasoning that half getting unnecessary side effects is better than half having untreated disease. But now imagine the same scenario, but in a setting with a lower incidence of TB, so that despite the same clinical presentation, only 40 patients have TB. What would you do now? Now imagine 30 patients with TB. What about 20? Reduce the number until you reach the point that you think it's better not to treat all the patients, because the side effects and costs outweigh the benefits. The number you got to will be different for different people, but might be somewhere between 5 and 20. Whatever it is, it represents an important line in the sand or threshold, as it's your personal point of indifference between treating and not treating a patient when no further diagnostic information is available. This particular value is known as the therapeutic threshold. Doctors tend to feel very uncomfortable about the therapeutic threshold. They usually want to give a range of values or make a bargain on getting some more information. But ultimately, for each individual patient, there is a probability at which you will initiate therapy and a slightly lower one at which you won't. There are different ways of calculating these values, but what's important is to understand the concept. Let's put it into practice and see how this framework might help us use tests more rationally. Imagine you're seeing a patient you suspect might have TB. Your therapeutic threshold for this patient is 20%, meaning that when no more information is available, you will treat if the probability is above 20% and not treat if it is below. After a careful clinical evaluation, you decide that the pretest probability of TB for this patient is 60%. You now have a new test available to you with a well-defined diagnostic accuracy, but should you use it or not? Currently, the probability of TB is above the therapeutic threshold, so if no more information was available, you would start treatment. A positive test will only increase the probability, so cannot influence your decision to treat. The key question, therefore, is whether a negative test can reduce the probability below the therapeutic threshold or not. If it can, it will change your clinical strategy from treat to don't treat. If not, you'll treat the patient even if the test is negative, so it can't help you with your decision making. Remember that negative tests reduce probability, and we calculate a negative likelihood ratio, which is a number less than 1. In this case, I did the calculation and determined that only if the likelihood ratio is 0.16 or lower will it reduce the probability of disease below 20%. This is what people mean when they say that you should only do a test if it will change the patient's management. i.e., if you only have one test left, it can only change the patient's management if it can shift the probability of disease from one side of the therapeutic threshold to the other. Again, these concepts often make doctors feel uncomfortable. There's a tendency to want to do a test just to confirm the diagnosis. While there might be justification for this in some scenarios, you must remember that there are costs associated with doing tests, and we have a responsibility to make the most rational use of resources. In summary, clinical thresholds are points of equipoise between decisions to test, treat, or not treat on the continuum of probability. Understanding these concepts can help you use tests more rationally.